Hello everyone, I'm Leslie Cornwell, certified nurse midwife with Midwifery Business Consultation. This next section of the course has to do with postpartum hemorrhages and the potential complications that can happen in the postpartum period. Postpartum hemorrhage is something that is very serious, especially around the world. Third world countries, we take for granted the basics we have with Cytotec, Pitocin, IV therapy, just some of these things we can access that many women across the world die from. So postpartum hemorrhage is a very serious complication of birth and needs to be taken seriously. There's a lot of active management of labor that is got a lot of research. It tends to be the more hospital standard of care, but in out-of-hospital birth, we tend to do more expectant management, which is based on signs and symptoms, having the things available. And there are many midwives that will actually have a discussion with their clients. Would you like me to give you a little bit of Pitocin IM injection in your thigh after the placenta comes out? I would say honestly, most of the home birth midwives I'm aware of tend to do more the expectant management. They'll give the medications if there's a bleeding issue, keep the baby skin to skin, nurse right away. So we'll talk more in details. These are just the basics of a postpartum hemorrhage. The definition of an early hemorrhage, which is most of the situations, occurs when the blood loss is greater than 1,000 mLs the first 24 hours after delivery. Typical delivery, 300 to 500 mLs. This is based on medical research. I mean, my personal belief is they usually will call it a postpartum hemorrhage if it's more than 500 those first hour, because they're going to continue to lose blood. I don't think anybody has ever really said, oh, it's been 12 hours and now she's lost 999, one more ml. It's a big estimation. And especially the physiological normal blood loss from birth, I think it's more closer to 500-600 than that 300 to 500. There was many times in the hospital setting I would say, oh, 499 or 450, because I didn't want them to be categorized as a label of unnecessary interventions. So yeah, in the hospital setting, you get a lot of practice with estimating blood loss. When I did my on-site birth assistant courses, we would get the black cherry jello, some coagulant thickener of some kind, like some gelatin, and put them on pads and have the birth assistants, the midwives, actually estimate what that blood loss is. We would weigh it. And it's nice. You have a baby scale there. If you're ever unsure the actual amount, you can weigh the pad. She's got multiple pads there. You weigh a pad and then you minus that weight from the one that's containing the blood to get a pretty accurate. But most of the time, I honestly didn't have much issues with postpartum hemorrhage in the home setting birth center. It was really the hospital. I had to manage it more. I don't know why, just the extra anxiety, all the stuff around. A late postpartum hemorrhage has to do with after 24 hours of birth, and that's not as common. The couple of times I've seen that is hemorrhaging. They've been home for a couple days and there is a little bit of placenta fragment left in the uterus. There is an infection underlining, some other clot. There's something left in the uterus. Is the few times I've ever seen that as an issue. It's typically you're going to have the problem that first hour, keeping a close eye on that uterus staying nice and firm. So main causes of early postpartum hemorrhage, uterine atony, and that's when the uterus after the baby is born doesn't want to firm down. It tends to be after you've had more babies. It tends to be after, I've seen long labors, I've seen inductions, anything where that uterus is really tired. If there's lots of fluid where the uterus has really been stretched out, a big baby, twins, that can cause uterine atony. I've seen it with fast deliveries, shell-shocked maybe. I almost promise if there's a newborn resuscitation and that mom's stressing out, I pretty much always have bleeding issues with the mother because of that fight or flight response. Her adrenaline kicks in and the uterus doesn't firm up. So the first thing you usually do with uterine atony is you just want to rub on the uterus a little bit, get the baby nursing skin to skin, make sure the placenta is delivered. There's no clots, there's nothing else that's making it so the uterus can't get nice and firm. And then you start going into the medications, and in rare situations, a manual extraction by the midwife of a clot or a placenta, but that's more down the line. Other common causes of early postpartum hemorrhage have to do with lacerations. It's not just a little skid mark. It's those sneaky ones that tend to be deeper. You've hit an artery. It's just oozing and oozing, but it's not enough to make you think, oh my goodness, is this coming from the uterus? Is this coming from the vagina? Sometimes I've seen it where it's just a side, and maybe some of the swelling actually causes the bleeding a little bit more. I've had that happen an hour later where I'm checking the uterus and it's nice and firm, but there's still quite a bit of blood that's happening on the pad. You start going through your head, where's the source of the bleeding? I'll take a flashlight. I look really well inside the vagina as a midwife on all the walls of the vagina, and the labia, because you want to make sure that you put a cross stitch in those arterial and venous blood vessels that tend to be just oozing. They don't clot off and stop bleeding on their own. Retained placenta fragments. It's usually more a situation if you don't get all the placenta, if it doesn't deliver on its own, you had to go in for a manual. That's why it's so important to look over the placenta very closely after the baby is born. It's not a high priority if there's bleeding to do it right away, but if she's having bleeding, you can't exactly figure out the source, spend 30 seconds looking at that placenta. Was there an extra lobe that just got separated? Is there any parts of the placenta that's not intact, and then doing a manual exploration. It's really, really painful. So as a midwife, I keep that as like a last resort because it's not fun at all. So yeah, so that's another thing. It wouldn't be anything a birth assistant does. It's more just anticipating with being a postpartum hemorrhage. What are the things the midwives, there's multiple sources of where the bleeding is coming from. We have to figure it out. Inversion of the uterus. I have gratefully never been part of that situation. The time in the hospital that I had seen a doctor do it was the placenta wasn't ready to deliver and was doing a manual press on the top of the uterus and pulling on the cord, and the placenta didn't separate and it turns the uterus inside out and it actually comes out of her vagina. It's a medical emergency. I mean, she can go into shock and you can bleed very quickly. I mean, it shell shocks that uterus to come out in the cold air and to have an inverse. So it's a big, big deal when that happens. I mean, a lot of times, based on textbooks, you're pushing the uterus back in, you're doing a bimanual exam, and you're being very aggressive with the postpartum hemorrhage meds because it's going to take a lot to get that uterus to firm back up from what it just had go through that shock. So thankfully, it's extremely rare to see in the out-of-hospital setting when you do expectant management and let the placenta deliver on its own and you're not pulling and pushing real hard on the top of the uterus to have that happen. Placenta accreta, thank goodness, that is extremely rare. The few times I've seen it, it has to do with the women that have had scars on their uterus. Placenta accreta, there's different layers to it. It has to do with the placenta growing through the endometrial layer inside the uterus. And if the really bad one is where the placenta grows through the uterine wall and into her abdomen. I've been part of C-sections where it's into the bladder, it's into her abdominal cavity, and it's a very, very serious situation. Many times it's on multiple C-sections. That scar tissue is not a good protective wall to keep the placenta inside the uterus where it's supposed to be. So the times I've seen it was high-risk ladies, multiple C-sections. They knew ahead of time. They're having a big discussion with her about a hysterectomy before even doing the C-section because the chances of them being able to safely keep the uterus intact and even with the surrounding organs, depending on how far it's grown. So with placenta accreta, I've never had it in the out-of-hospital setting. Most of our ladies are low-risk healthy, but if you are having a placenta, it's been 30, 40 minutes, she's gotten up to the bathroom, you've maneuvered, you've nursed, she's not bleeding, and you can't get it to separate, do not aggressively pull on it. Do not snap that cord. Do not make the uterus invert out. There may be an unknown placenta accreta. If she is bleeding, you definitely have to actively manage. You definitely have to get the placenta separated, do a manual extraction. But if there's no signs of bleeding and you can't get the placenta to separate, this should be one of the things in your mind, and you do a transfer of care to the hospital where you're in a higher risk setting. Because by 30 minutes, most of the placentas typically will deliver on their own with going to the bathroom, maneuvering, nursing a baby. You start wondering why is this outside of the variation of normal? What could be the possible causes? And then hematomas. Hematomas are tricky because you usually don't know they're there. You don't get like that obvious bulge in the labia, vagina area to say, oh my gosh, there is a big spot of blood. It's usually the symptoms. She's acting like she's bleeding. Her vital signs, she's acting like she's hemorrhaging out, but there's no active sign of blood coming out of her vagina. There's no lacerations. Sometimes when the hematoma gets larger, she's going to have a lot of rectal pain. She's going to have a lot of pelvic pain. But initially that may not be the case. So hematomas are things you want to think about when you've went down your list of all the other stuff you've tried and you can't figure it out, but she's showing active signs. She's getting pale. You start an IV on her. It's not going to do you any good to give Pitocin and Cytotec because it's not her uterus. You got to think about when you're doing the fluids are to replace the blood loss that's occurring. Even though you can't actively see it, she's having symptoms. She's having that. So that would be my thought as a hematoma. I'd be looking very closely in the vagina, feeling along the walls to see if there's any tender spots or if I can feel it deeper in the tissue, a hematoma. Sometimes you can, sometimes you can't. Cervical laceration is another one that's pretty rare, but can cause pretty significant bleeding. You have to go deep inside the vagina and look with a really good flashlight. And if you can see the source of it, you put a cross stitch. It's very difficult in the home setting with the current equipment to stitch a cervical laceration. The couple times I've had it, it was putting pressure with a bimanual exam and then just leaving the pressure for 20-30 minutes and just having it end and coagulate itself versus a stitch. But sometimes you have to transfer if one can't put a stitch in the source of the bleeding. Uterine atony. Myometrium fails to contract and the uterus fills with blood because of the lack of pressure on the open blood vessels. So think about, she just had her baby, that uterus was stretched to the max, it just had a baby in it, the fluid came out, that placenta is attached to the uterine wall, and as soon as the placenta detaches, those are all they're fresh blood vessels. That's where she has her lochia for the next few weeks from. You want those blood vessels to contract. You want them to get firmed up and stop bleeding. If her uterus doesn't firm up, she's just going to keep bleeding and bleeding from that site. So the nice thing is when she's delivering instinctually, she's delivering in hands and knees, the water, the squatting bar, all those things take advantage of gravity. She's skin to skin with her baby. She's in a comfortable environment. Her anxiety is not going through the roof. I really had rare issues with uterine atony in the home setting. In the out of hospital, it tended to be my hospital births. I would do the same thing, but there's just so much going on. There's so much tension and anxiety, and they tend to deliver more on their back, and there's just extra things I would have to do for those deliveries to help get the uterus nice and firm. So these are different causes of uterine atony. I know I hinted at it a little bit earlier. Having many babies, grand multiparity, intrapartum stimulation with Pitocin, that has to do with whether they're in induction, they get labor started with a medicine in the hospital setting, or augmentation, where the labor isn't going as fast or needs a little help to get to the next level. Anytime you're stimulating that receptor site with Pitocin above and beyond what her body is making, once it comes time for that big surge after the baby comes and she's nursing, those receptor sites are tired and they're going to need a higher dose of that Pitocin to really clamp down. So those are the ladies you want to be careful with. Prolonged labors, anything having to do with that uterus being tired, older, she's had a long labor, she's has a big baby, she's a little bit older. I mean, there's just, when your body is tired, muscles don't work as well. So prolonged labor, if she's 16, that makes a big difference compared to 36. If it's a 6-hour labor versus a 24, 36-hour labor, that it definitely affects the uterus, the muscle, and its rigidity. Trauma during the obstetrical procedure. So that has to do with assisted delivery. So if it's a vacuum assisted delivery, if it's a forceps, there is a lot of quick things happening that the body didn't naturally do. The body, when you are pulling a baby out of a woman's body, her body isn't actively pushing the baby out. The body takes a little time to catch up to say, oh, there's no baby in here anymore. The uterus tends to be, and the stress, I mean, the mom, there's a reason they're doing that. The mom's going to be more stressed out. If her baby has heart tone issues and they want baby out, she's already got the adrenaline and fight and flight motion going. If she's been pushing for 6 hours, she's already exhausted. There's a reason they're doing that assisted delivery. So anytime there is a assisted delivery, there's some sort of trauma, there's some sort of medical condition, you always got to be watching for bleeding. Over distension of the uterus, that has to do with the uterus muscle being, it's a balloon. It's filled to its max level. It takes more work to shrink it down. So that has to do with twins, big babies, lots of fluid. That's a big distension of this muscle that just takes more work to firm down. Excessive use of anesthesia, so epidurals. I did my thesis study on graduate school with epidurals and just the true informed consent that needs to be given to families, because you're not upright, you're not moving around. Typically they need, it's a intervention leads to intervention. If they get an epidural, they tend to need something to help get labor going. So now you're augmenting the process. They tend to be on their back. They tend to have a Foley catheter. They're not moving as well. The pushing time is longer. The labor is longer. It adds up to more and more things that put you at a higher risk of bleeding after the baby comes out. And that might have been part of just the hospital experience. My ladies didn't have any epidurals at home. They were upright, they were moving, they weren't being induced for one reason or another. So low risk women tend to have less risk factors for bleeding after delivery. So the most common cause of a hemorrhage is really just being tired. It's just that uterus is wanting to firm up. The fight and flight kicks in. There's that underlining clot that's present, but I truly believe it's just giving her a supportive, strong environment, getting her baby skin to skin, getting her nursing right away, being upright, that squatting. It makes a huge difference. The key to management is prevention. It's education. It's not doing things to the woman that makes her having a higher chance of her uterus not firming up. So we talk about it like as nurses, birth assistants, midwives. It's great to have a discussion at the beginning of labor, her story, her risk factors, her situations, things we're thinking about. And then when you get close to delivery, especially if it's a longer labor, just touch base on the things, especially as a midwife being very experienced and you're a newer birth assistant, you want to have a good discussion of what are the things you're thinking about. Are you thinking we should keep the Pitocin or the Cytotec or an extra dose of Pitocin close by? Should I have it already drawn up in the needle? What are your thoughts? I mean, sometimes there are no risk factors and it happens, but there tends to be things you're just thinking about, and it's important to have clear communication with each other. So uterine atony, signs and symptoms. These are the different causes of why the uterus is not firming up. So a boggy uterus is a soft uterus. It does not respond to massage. Massage is not very comfortable. Massaging is taking the midwife provider's hand and rubbing on her lower part of her abdomen, trying to get it so it's not real soft and squishy, so it feels like there's a small softball of firm muscle that tones up in there. So you're rubbing and trying to encourage it to firm up. Abnormal clot. So if I'm doing my rubbing and it's not even softening up at all, and the placenta, there's quite a bit of clots coming out, or the uterus is getting real big and I push on it and then all of a sudden I get some clots and a bunch of bleeding, I wonder, okay, what's left in there right now? Excessive bright red bleeding. There is a fine line of she's going to have bleeding after the baby comes out. But when I start getting concerned is when it's like a trickle, like pee. When I have a pad underneath of her and I changed it 15 minutes ago and there is a pool of blood underneath of her, and that's past that first hour. I mean, usually we're checking things out. There's a lot going on where I'm keeping a close eye on it. But that's something you learn with time as a midwife, as a birth assistant, a midwife apprentice. how much is too much. If she's walking to the bathroom and there's just a little triggle here and there and it's just going down her leg, I'm not so stressed by that. But if she's acting like it's actually a pee where it's coming out of her vagina, it's dripping and not even going down her leg, and it's just a full-fledged pee flow, that's too much for my comfort level. And I just get her to the bathroom, I let her rub on her uterus and see if we can figure out the root of the cause. As a midwife, I keep in the back of my mind, what was her iron level? What was her CBC the last time we checked it? Did we check it at 36 weeks? Did we check it at 28 weeks? Did we just check it at the beginning? Does she have a history of anemia, low iron? I'm going to be much more conservative in my management of a woman that doesn't have as much blood to lose as someone that has a really high iron hemoglobin level. So those are things. Women are meant to lose some blood during birth, but there's some women can compensate for more blood loss than others. So how dehydrated is she? I always like to keep the water up with them pretty consistently, because if they're dehydrated, they're already going to have a lower blood volume than the average woman. Unusual pelvic discomfort or backache, that has to do with just that blood kind of pooling up in her uterus, and it's causing distension, it's causing a lot of pressure. She's really uncomfortable. I tend to see that symptom similar to when the placenta wants to separate. So if the placenta is out and she's acting like she's going to birth another placenta, I get a little concerned, and I definitely want to assess what's the bleeding, where's the source of the pain, what's going on. So management of uterine atony, we talked about it a little bit. The first line of defense is just being able to know what could be the possible causes, what are the more common causes. So usually the uterine atony is just a tired uterus. Give it a little time. If she's got great iron, she's overall healthy, I just am patient. I tell her to nurse the baby. I myself or her would do a very gentle rub, and usually in 30 to 60 seconds, the bleeding will stop on its own. So that's usually my first line. But if it's like pouring out of her and it's not even just a little trickle, I don't mess around. I'm a little more aggressive, because women can die in minutes if you're not careful. If you don't get the source of the cause, and she has this flow for 5-10 minutes, this is how women die from childbirth. So I take it very seriously, and I think about in my head, I have open, calm conversations with the women. It's really important to be able to be confident, calm, and clear communication. That's with any emergency, any situation. You're right in front of her. You're talking to her. I'm sorry you're bleeding more than I would like to see. The placenta has delivered. I think there's some clots left in there. You're not going to like me for a second. You're bleeding too much. Your uterus isn't firming up. I have to go in with my hand for about 10 seconds and get that clot out, get that piece of placenta, whatever the situation. Versus I just do things to her. Yeah, it's amazing what 30 seconds of communication to give a heads up of what's going on, really it affects her anxiety. There's such a deep trust between the midwife and the client she's serving anyways, that she knows I'm not going to do anything to harm her intentionally. Our goal is to have a safe mom and baby. So we want to manage by figuring out the underlying cause. If it's a uterine atony, I've tried to massage it. I tried to get out clots. Because Pitocin and Cytotec are medicines that you can give for it, but they take time to kick in. Pitocin, giving as a 10-unit injection, is going to take a few minutes to kick in. If you're giving a rectal Cytotec versus oral, either one takes a little bit of time. The rectal is a little bit faster than the oral, but the oral is just chalky and doesn't taste very good. And I tend to do the rectal just because it's quicker. I can move on. I know it's in versus I'm waiting for her system to break it down. But that's still going to take 10-15 minutes. So that's more of a long term. The Cytotec isn't given to stop this immediate bleed. It's given to help keep the uterus nice and firm for a longer period of time, because she's already lost blood. I don't want her to lose any extra in 10, 15, 20 minutes from now. So there's different things you can do. If it gets more extreme, I'll start an IV, which is super rare that I do in the out-of-hospital setting, but these are just things you're wanting to document. If it's more, you're just keeping an eye on things. Every 15 minutes after the baby's out, you've done your repair, they're snuggling together, I'm documenting where her uterus is at. Is it in the middle? Is it off to the side? Is it up? Is it firm? Is it soft? Is she having a lot of pain, more than I would expect after having a baby? what does the bleeding look like? Is it bright red? Does it have a stinky odor? Are there clots involved? Like, if you start getting a lot of bleeding, you actually want to do more of a quantitative blood loss versus an estimated blood loss. So it's just being real clear communication of what you're doing, what you're thinking about, and what are the next steps. So fundal massage, we already talked about it. Bimanual compression more is a aggressive, where I can't figure out the source of bleeding. I'm waiting for these meds to kick in. We're waiting for the emergency services to get there. We've already started the IV. Bimanual compression tends to be my last resort for, there is a sulcal bleed, which is like deeper in the vagina, underneath the cervix area. There's a cervical tear. There's something I can't figure out the source of the bleed, and I just want to put some pressure to have it clot naturally on its own, or while I'm waiting for the medicine to kick in, I'm keeping that uterus nice and firm. So bimanual compression I rarely did because it was very, very uncomfortable, and it's more of a last resort to really try to get that uterus firm. Assessing your vital signs. This is a great thing for the birth assistant to do. You want, I don't really care about her temperature. I want her blood pressure and her heart rate. And I want to know her oxygen level. I mean, is she hyperventilating? Is she, her capillary refill tells you her circulation. Women are going to compensate with their vital signs till it's too late. Shock on a pregnant woman because she has all that extra blood is going to be one of the last obvious signs of vital signs. You want to be more subtle. You want to, I care more about how she's acting, having an idea of how much blood is okay and not okay based on her iron level and her personal story. And you do an assessment and you just have critical thinking skills of step by step. So the vital signs are important, but it's not, if I only have 2 of us there, the highest priority is getting the meds, making sure baby is good, making sure where's the source of bleeding. I'm not going to change my management based on a blood pressure or heart rate. If we've got her stabilized, I knew what she was before she delivered. Now I want a trend of her vital signs. That would be more something a little bit farther when you've just got 2. If there's more people at the birth and you can help delegate things, great, awesome, but that's usually not the case. So we talked about the medications. These are typical medications. Pitocin and Cytotec tend to be the first line in out-of-hospital births. Methergin and Hemorrhage tend to be more the second line choices, along with Cytotec in a hospital setting. Methergin and Hemorrhage have more risk to them. The transport, the refrigeration, the price, the contraindications of who you would use them on. There's just more to worry about. Methergin you wouldn't give to a woman that has blood pressure issues. Hemorrhage you wouldn't give to a woman that has asthma, respiratory issues. So there's more risk. Like Cytotec is a pretty safe med. Pitocin is a safer med. So in a hospital setting, it's pretty rare that I see Methergin and Hemorrhage being used for helping with uterus being firmed up. It tends to be more of the higher risk setting and keeping a closer eye on the moms. So physician's consult, this would be the point where you're in the home setting. Is your birth center, is your home 5 minutes from the local hospital that has labor and delivery services, and you could just get her in the car and give them a call and go right across the street? Or does she live 45 minutes out in the middle of nowhere, and it's going to take time for an ambulance to get there? It's going to take time to get to the local hospital. You have to be thinking about these things when you're doing your birth and you have your transport plans and you have that critical thinking skills. Isn't just about this mom situation, it's your setting situation. So I am more conservative. If I'm 30-40 minutes from the closest hospital, I would much rather my meds kick in before EMS gets there and I turn them away versus I now wish EMS was here and we need to go now. So I'd have that. I'd have a few times, and I had a great relationship with the local facility, and we'd have clear. I said, I don't think we need to transport right now, but I know it's going to take you 15-20 minutes to get here. I'll let you know if she gets better, but I'd like you to start heading over. Those kind of conversations I'd much rather have versus I need you now. We needed to have left 5 minutes ago. You're going to have a much more stressful situation, a lot more dangerous situation, and breakdown in communication. So some of the things with a physician's consult is maybe minutes don't matter, but we can't figure out the source. She's not going to die in the next 10 minutes, but she can't keep bleeding how she's bleeding, and I can't figure out the problem. So as a midwife, a D&C, a doctor may do, where they just go in with some lovely instruments and scrape the inside of the uterus, because there might be some real small clots, or might be some real small placenta pieces, or I've seen it too with just the amniotic sac, can cause some problems in a few days and be that underlying infection that may or may not be removed by the woman's body. Hysterectomy is very extreme. That's the actual removal of the uterus. I've only seen it like rare, thank goodness, because they can't even figure out the source of the bleed, or it's like that placenta accreta where it's caused so much damage from the placenta growing through the uterus. Replacing the blood and fluids. So if she has a hemoglobin that started out around 12 before delivery, and now she's at like 6, most women will start having symptoms when they get below 7, 8, when they're used to having that much. She lost half the blood in her body about. So sometimes they'll go and they'll need to replace, even though the bleeding has stopped, she has lost so much blood. It's important to do a risk benefit of replacing that blood and fluids. Women that have real low blood volume, even though she's stable at that point, she's going to have a higher chance of infection. She's going to have a higher chance of depression, poor milk supply. There are so many complications if she's showing symptoms and has a low iron level that a blood transfusion might be the best option for her. So postpartum hemorrhage, the other causes are lacerations. So that's a tear that can be in her vagina, that could be on her labia, clitoris, perineum. It just depends, and especially when they start getting more significant tears, a tear on like a 3rd degree or a 4th degree, where it goes partially through the rectum or completely through the rectum, you have a much higher chance of significant bleeding from those. I've never had a postpartum hemorrhage from a laceration that's a 1st degree. That's just superficial. Rarely do we even stitch that. A couple times from 2nd degrees, it's just a little deeper in the tissue. But yeah, when you start getting 3rd and 4th and you've got that much tissue that's been exposed and damaged, you have a much higher chance of blood vessels that can be bleeding from, that need to be stitched right away. And so that's why it's really important as the birth assistant, have a good light, keep sterile technique, handing gauze, keeping things nice and clean so that the midwife can see the site that needs to be stitched for the bleeding. It's definitely a team effort to stitch those areas relatively quickly. It can be affected by the size of the baby. Bigger babies have a higher chance of lacerations. The presentation of the baby, if it comes out breech versus vertex, head down. Position. So if there's a sweet little hand and the baby comes out waving, those women get nasty lacerations from not having that perfect circle of the baby's head coming out. So just being aware, looking deeper in the vagina. If they came out with a hand presentation, shoulder presentation, I'm looking at her vagina and her perineum very, very closely as the midwife. So signs and symptoms, it's similar to the uterine atony as far as bright red bleeding and signs and symptoms of hypovolemia, but the uterus is nice and firm. That's not the source of the problem like the last part. So if I have a nice firm uterus, I'm getting no clots, but I'm getting a steady pea-like stream of blood, my next thought in my head is a laceration. I need to look at her bottom very, very closely. And it's hard. She's painful. I give them local, but it takes time to kick in, and you don't have 3 to 5 minutes to say, oh, I'm going to sit here while your local kicks in. So it's a balancing act when sometimes these things are happening. So the big thing as the birth assistant, the midwife assistant helping out with the team is just being able to look at her bottom really closely, having the sutures, talking to your midwife team. What do they like to use? Okay, do they use just the typical Vicro, Chromic, what size needles, having them ready, knowing in your birth bag where everything's at. The suture set, the extra gauze, the pads to replace underneath of her. That's your role as the midwife assistant, the birth assistant, is really to be able to help out, to have things close by when the midwife asks for them, and so that the source of the bleeding can be resolved. Vaginal packing is really rare. I've seen it where a nurse has done it in the hospital setting because the doctor's not there yet and just wants constant pressure on a site till the doctor or midwife working in the hospital can suture it. But with our setting, we want to just find the source of it. And if I can't find the source of it, I'm usually taking gauze and manually putting pressure with my hand on that site, because then I can actually feel, okay, am I getting the right spot? Is it bleeding too much? And that helps with the assessment determining should we be transporting, or is it going to clot on its own? And then the blood replacement is more of a last resort if she's just lost so much and needs to have the blood and fluid replaced in her. So test yourself. So you are assigned Mrs. B, who delivered vaginally. As you do your postpartum assessment, you notice that she has a large amount of lochia rubra. So that means she has a lot of bright red bleeding outside of her vagina. What would be the first measure to determine if it is related to uterine atony or a laceration? So the first thing that I would do is I would ask her, how are you feeling? When's the last time you went to the bathroom? How long has it been going on for? Just some basic questions. Is the baby nursing at that time? Is it not? And I would instantly put my hand on her tummy. Is the uterus nice and firm? Is it up? Is it off to the side? Are there clots coming out when I press on her uterus? Is it soft, or does it feel like a softball? So if it's up or off to the side and she's bleeding a little more, it's usually a simple fix. Her bladder is full. We just gave her a bunch of water. We had her take some Motrin and eat. So now I calmly walk her over to the bathroom and I let her pee. And usually the uterus comes down and her bleeding will resolve. If I press on her uterus and it's up and there's clots coming out, I wonder about, okay, any underlining, did I get the clots out? Are there more in there? Is there a little bit of placenta? What's causing her to make clots right now? If the uterus is nice and soft, then that's uterine atony and we need to get it firmed up. So massage, get the baby nursing. We may have to consider some medicines, Pitocin, Cytotec. But if her uterus is nice and firm, it's small, it's midline, there's no clots coming out, the next thing I do is think about lacerations that I had missed and do a very good assessment of her perineum and inside her vagina. Retained placenta fragments. This one's trickier. It could be a complete placenta or parts of the placenta. That's why our goal is to do more expectant management and let the placenta deliver on its own and separate on its own. If you have to do a manual extraction, it partially separates, or maybe there was some scar tissue or part of the placenta adhered to the inside of the uterine wall, you may have to go in for a manual extraction as a midwife, and that increases the chances greatly of a postpartum hemorrhage, and it increases chances greatly of placenta fragments and uterine atony. When there's placenta fragments, it's hard. You have to be aggressive. You have to feel around the inside of the uterus with a sterile glove. It's not fun for the midwife, and it's not fun for the client. So it's rare, thank goodness. The uterus is boggy or relaxed. It tends to be darker bleeding when it comes from inside the uterus at that level of flow versus bright red bleeding like lacerations. If you can't get the placenta to separate, the uterus isn't going to firm up and she's going to keep bleeding from the other parts where the placenta did separate. So it's a pretty quick transfer. And then they'll have to do a DNC, get her comfortable. It's a pretty quick process to make everything happen. I'm giving her lots of meds, anything I can do prophylactically. I put my hands in there a few times. She had a surgery. They're going to do preventative antibiotics in the hospital setting. But my main goal being out of hospital is if I can't remove that placenta, I can feel it in there. I got part of it to remove. I know there's still placenta left in there and it won't detach. I'm not even messing around. I'm giving her the IV started. I've called 911. I've got my Pitocin, my Cytotec, and we're going because I can't get it. She needs the additional services of the hospital setting. So hematoma, this is rare, but I've seen it a couple times. It's you went down all your list of everything, and a lot of times the woman will have very severe pain, more significant than the typical afterbirth pain with a woman that's had a few babies. It's just constant, it's severe, or a lot of rectal descriptions with it. She acts like she has to poop really bad, even though she maybe pooped during labor. There's usually not much in their system. If she's telling me she has intense rectal pain, my mind is instantly thinking hematoma. I'm checking her vital signs. I'm checking her bleeding. I'm seeing if I can get a localized vaginal exam. So if I can feel where there's a specific location, sometimes I can feel the bulge as a midwife. There's different kinds. It's many times concealed. It's deeper, and you're just getting it based on her vital signs. If she's acting like she's bleeding and I don't see a source of the bleeding and she has tons of rectal pain, I'm calling for the hospital, because she can still die from this. It's a very serious thing. I'm not going to give her Pitocin and Cytotec. She doesn't need it. Her uterus is totally fine at this point. If she starts getting uterine atony, which sometimes happens when the shock kicks in, we will definitely go for that next step at that point. But it's one of those things that in the hospital setting, if her vitals are staying stable, and even in the home setting, if it's like, oh, you have a vaginal hematoma, there's a bulge and it's not growing in size, and her vitals are stable, we'll just watch it closely. I've had a couple ladies where they've had pretty significant varicosities in their labia, and that was one of my worries. And we did a decision to transport for an induction. She had very severe pain from her varicosities, but I also worried about getting clots and hematoma after delivery in her varicosities. And she had that happen, was a hematoma. So there's risk factors to think about. Most of the time it's really rare to have a hematoma, and sometimes the hospital setting will actually have to drain it and pack it, but most of the time, as long as she's not having significant continued bleeding from that site, just keep a close eye on it. Inversion of the uterus, that's that rare, very significant situation. The couple times I talked about it was when in the hospital setting where there's a lot of aggressive tension, attraction on the cord, and it can make the uterus turn inside out when the placenta is being pulled on. I've never seen it naturally happen on its own. I've seen it happen with medical interventions. And so it can be a complete inversion. It could be partial, where it's turned inside out, but once you turn it inside out, it goes in shell shock, and it's really hard to get it firm again. So you don't mess around. If you have that rare thing in an out-of-hospital birth where the uterus turns inside out because of the placenta being at the top of the uterus and the cord being pulled on, and you push it back in and you put bimanual pressure as a midwife, and you're calling 911, this lady is going to have significant postpartum hemorrhage issues once that uterus turns inside out. So just, natural birth, let things happen on their own, and it shouldn't happen. And then these are just some pictures showing that better description. It typically, when the placenta is attached to the top of the uterus, called a fundal location. But many times when we're not looking at the ultrasound, and maybe you note she has a fundal placenta, and you have to be very careful with that cord not to be super aggressive, because you can easily turn her uterus inside out. So inversion, like we were talking about with the bimanual, you're literally taking your fist with a sterile glove as a midwife and pushing it back inside of her. It's so painful, and that uterus is so stunted after it happens. So we talked about it, the treatment and the care. You want to replace it quickly as possible. She is going to go in shock like no tomorrow. I don't even mess around at home if that rare thing happened. It talks about a little bit like the NG tube and more of a serious stuff that would be done in the hospital setting. What I want as a birth assistant, midwife team out of hospital setting, if that uterus turns inside out, the birth assistant, start calling 911. Even when the midwife's pushing it in, it's like, oh, we got it back in. Don't mess around. She's going to go in such a combat shock that uterus, it was cold. It was totally turned inside out. It's going to take a lot for it to firm back up. She's going to need a lot of antibiotics. She's going to need a lot of medications to prevent postpartum hemorrhage. Placenta accreta, we talked about it briefly. That's when the placenta grows past the uterine wall where it's not supposed to. There's different levels of what that can happen. The times I've seen it is when she's had multiple C-sections, and that's where we always have to be careful with a vaginal birth after a C-section. Even if she's just had one, scar tissue tends to be a magnet for placentas, and multiple D&Cs, multiple miscarriages. Anytime there's lots of scar tissue inside the uterus, you want to be more careful the placenta location. If she has an anterior placenta where it's at the front part of the uterus and she's had a C-section before, I always worry, and they're probably not the best candidate to do an out-of-hospital birth because that scar tissue doesn't put a protective barrier. The placenta has like a roots of a tree and it just grows and grows and grows. So if there is a placenta accreta noted on an ultrasound, those women are not good candidate for out-of-hospital birth. They're not delivering vaginally. It's usually a C-section and high risk preparation because of the concern with high bleeding and potential of losing her uterus. So this one, the time that would matter to you guys in out-of-hospital setting is you just know there was a placenta accreta. It's rare. It's seen on ultrasound unless it's pretty significant. It's been more than 30-40 minutes. There's no active bleeding. The placenta is not separating. It's not detaching. I would not go in and do a manual. I would not, that would be thinking in my head, why is it not separating? What is keeping this placenta attached to her uterine wall more than it should be? So then you would transport and you would have the doctor do the manual extraction or remove it in the OR because of that thought process and being overly prepared. If the uterus is not making the placenta separate, do not manually go in if there's no bleeding. If there is bleeding, that's a different situation. You want to try to separate the placenta. So treatment, if there's a small portion, usually you can remove it manually, but there's no way to assess for that. If it's a large portion of the accreta, a lot of women will lose their uterus, which is so sad. I mean, to have a 21-year-old have a hysterectomy and not be able to have kids anymore is a really tough grieving process. So these are some things I want you to just kind of go through and make a little mental note. Is this considered part of early postpartum hemorrhage that'll occur the first 24 hours after 1,000 mLs of bleeding? Late postpartum hemorrhage, it occurs after the first 24 hours. It could be up to a few days later, or both. Could it happen either time? So for uterine atony, what do you think? So I would say uterine atony is typically early, but I've seen it once in a while late as in the infection, or there's a clot that was so small that the uterus could firm up, but now there's an infection, and infection causes inflammation. So it's really rare to have uterine atony be a later cause of postpartum hemorrhage, but it can be there. Typically it's early. Retained placenta fragments. Most of the time that's also early because the uterus can't firm down. A lot of these will be interconnected with each other. A cervical laceration, I've honestly never had a time where it's been late. If she's going to have bleeding problems, she's going to have them right away from that blood vessel being open. If it's later, she's already clotted it off and taken care of it herself. Inversion of the uterus, that's a medical emergency and that's early. It wouldn't even occur after 24 hours. It's that time where the placenta is being separated. Placenta accreta is going to cause it right after birth, usually during the C-section, or the placenta tries to separate and part of it or all of it can't, and it's grown inside. So that's an early one. Hematoma, that can be both. That can be right away, depending on how severe it is, or it can be later if it's a slow trickle that nobody caught. I mean, I had a lady day 2 postpartum, very classic postpartum hemorrhage symptoms, but she wasn't bleeding anywhere. It was what she was describing to me. And when I went out and seen her, she had, so most of the time it's early, but I've had a few where it's just a slow trickle and it just builds and builds with time. And she's bleeding on the inside and getting more and more rectal pressure. So postpartum infections, infection of the genital tract that usually happens the first month after the baby is born. It could be after a miscarriage or a delivery. Mastitis is also another infection that's specific to the breast. Can be from a cracked nipple, from Stress, typical mom things. She could be not nursing well. She could be not emptying her breast well. She could be not drinking enough, not getting enough sleep. So there's a lot of different things that can cause infections. Even having a postpartum hemorrhage and depression and low vitamin D can cause infections because the immune system is weaker. These are common bacteria that will cause the infection. So that includes strep, group A, or B, and then E. coli. So endometritis, that has to do with an infection inside the uterus. There's a lot of different reasons that can cause it. Most of the time it's from some sort of trauma. Maybe something's being left inside the uterus. Maybe there was a long time the water had been broken, so that protective barrier between mom and baby, GBS positive, group beta strep, anything that increases the chances of infection, multiple vaginal exams, manual extraction of the placenta, a hand pushing the normal bacteria from her vagina into her uterus, trauma, so if she has a cervical laceration, she has multiple exams, hemorrhage, anemia, hematoma, that has to do with just a weaker system. She doesn't have as much blood circulating. Long labors makes people tired. Bladder infections, the uterus and the vagina are close to each other. Depression, anything that's mental health that we can see immune system just really does a number. Diabetes, hypertension, comorbidities, obesity, they increase the chances of infection. So yeah, at the bottom, just generalize. Most of our postpartum women can have risk factors for infection. So keeping a close eye on them, keeping them as healthy and well taken care of is so important. So yeah, I mean, I personally, with my third kiddo, significant endometritis because of a little bit of small clots that were left in my uterus by day 5. I went from being amazing, great third home birth to within 12 hours, flu-like symptoms, uterus getting boggy, foul-smelling discharge after a couple of days of antibiotics in the hospital, going home, and then starting to bleed a lot, needing a D&C. So it can spiral into one thing after another, and just keeping a close eye on these ladies. So critical things to remember with a uterine infection, they may or may not have a temperature, but if they do, it's above 100.4 for a couple of days. As I described, that flu-like symptoms is what I had. Malaise, feeling tired, heartbeat. I described it like I felt like I got hit by a truck. Like even though I just had my baby, I was getting way better. And then all of a sudden I felt like I just birthed and had a 3-day labor. I could tell myself declining quickly. I didn't have as much of the pelvic pain and the white blood cells just because you've an infection in your body. Definitely the foul smelling discharge. It's not the typical blood menstrually flow you would expect. It smells stinky. It smells like something is rotten. So it can happen up to the first week. And usually not the first 24 hours. It's usually after things have been left and the bacteria has time to grow, and it just gets people sick. So the different ways of treatment, definitely antibiotics. I've had a couple times outpatient, but the main standard of care is inpatient antibiotics. It sucked being day 5, having a brand new baby, wintertime, getting lectured by the nurses. But I knew it was important. I knew, yes. So you got to have a balancing act of what, like mastitis. You don't mess around with mastitis. They can get abscesses, that'll cut their milk supply. They can get really sick. They can get a blood infection. There's a lot of things you don't want to mess around with. Providing a warm sitz bath. So if she has endometritis, you want to make sure you're giving good hygiene, comfort measures if her bottom's hurting a lot. Promoting the drainage, so laying in more of an upright position so that that discharge doesn't just pool in the vagina and just recirculate back into the uterus. A lot of fluids, drinking lots of water, trying to flush the infection out of the body, and it just keeps you healthier. If your cells are dehydrated, they can't function as well and they can't defend against infection very well. The uterus, keeping it nice and firm. Depending on how far postpartum she is, you may or may not give Methergin. If she's not having bleeding issues at this point because of it, just keeping it in the back burner, that the uterus, depending on the location of how significant the infection is, she may or may not have it. Like with me, I had not much for bleeding concerns. It just was absolutely nothing at day 5, and then it slowly increased to trickles and more. It wasn't a postpartum hemorrhage until I got home about an hour after 2 days in the hospital, and then I quickly went in and did a D&C. So everybody is different what happens with endometritis, but it's definitely something you don't want to mess around with. The good thing is it's rare, especially in out-of-hospital births. And making sure pain medicine, I mean, Motrin, Tylenol, things that are compatible with breastfeeding is so important, because you're sore, you're hurting, you're cramping a lot, your uterus is trying to expel this bacteria and inflamed. And yeah, my uterus was very tender, and the woman's uterus, above and beyond just having a baby tender. This one is really rare, but just the suctioning, if it gets pretty significant into that intestinal, the peritonitis, but that's pretty extreme, and they'd be inpatient at that point. Other possible postpartum infections, these are rare, but it can happen. You can get cellulitis anywhere in your body, and it can even be in the pelvic area, in the abdominal area. And so it's pretty significant. If she's getting really sick with any of these symptoms, spiking a fever, chills, very tired, just not feeling good, you don't mess around. Talk to your collaborating provider and get some additional testing and figure out what's going on with her. There's a balance of being midwives and taking care of low risk healthy women versus the extensive training that physicians have to help support these. So preventing is so important on so many things. We talk about prevention during labor, drinking lots of water, getting snacks, keeping our strength up, keeping the care team up, pushing in optimal positions, breathing well, getting good oxygen to the baby, keep an eye on things. So there's a lot of preventative ways. So minimizing our vaginal exams, taking the healthiest of women, having a well-balanced diet. If you got diabetes and high sugar in your system, you're going to have a much higher chance of infection versus you're getting your vitamins, your minerals, and getting a low sugar intake. Good postpartum hygiene. We want to make sure she's changing that pad often. She's wiping the basics, wiping from front to back, using that squeeze bottle, the peri bottle, after every time she pees. And so even during labor, I think it gets taken for granted just because we're putting on a sterile glove. Every vaginal exam you do, it's not what's on the glove that causes the infection. It's the normal vaginal bacteria that we're pushing up inside the uterus. There's not much mixed information or research avoiding intercourse late in the pregnancy. I haven't found any hard studies, but that could potentially reduce the risk of infection. If her water's broken, you don't even mess around. That protective barrier to the baby is gone. So localized infection, so if she has an episiotomy, a laceration, like a C-section, a wound infection site, it's going to be very red, sore. It's firm because it's got a lot of inflammation to it. It's tender to the touch. It's very extreme pain. It could be from the suture. Maybe she's having an allergic reaction. Maybe she's pulled one of the stitches, did too much. You just have to do a good assessment. See if it has any drainage from the site, if it's real oozy pussy versus just normal inflammatory response of healing. A lot of cleaning of the wound, the site. You may or may not need to take the stitches out. If it's pretty significant, I get a doctor involved and they may have to clean the wound out directly, like especially a breast infection when it gets to abscess. It's just so nasty. Definitely need antibiotics for her. Sometimes some triple antibiotic ointment on the local site, but just oral, and sometimes IV antibiotics to get through the whole system. Postpartum cystitis, so that has to do with just a postpartum bladder infection. I say it's very, very common. The weaker immune system, not drinking as much, sleep deprivation. So just the signs and symptoms of a bladder infection are very similar postpartum to when they're pregnant and not pregnant. Increased urination, can't completely empty, burning with peeing. You really want to make sure you're encouraging, even if you don't feel like you have to pee, go to the bathroom and pee. They're used to a baby reminding them to empty their bladder. Once they're nursing and their bottom is sore and they're afraid of pooping, they're afraid of peeing because it burns, they're going to avoid going to the bathroom. So that's a really important discussion to have for being preventative. If she does get a bladder infection, you could get some cranberry pills. You can get some simpler antibiotics for her, and definitely getting those started because it can get into the kidneys and get her more sick quickly, being postpartum and weaker immune system. So there's just different things that can be causing it, but the main thing I tell people is just to pee off and drink lots of water and take good care of yourself. Sleeping, eating good food, that's so important to have that support. Mastitis, that's a nasty one. I've had it 3 times, and each time I got it, it was way worse. So I'm very empathetic to this infection. And mine was my kiddos being 1.5 years and traveling, and the flight and the not being able to nurse on a normal schedule, the jet lag, the sleeping. You don't mess around with mastitis. A lot of women will have flu-like symptoms before the redness even shows on the breast. The redness tends to come about 6 hours before the symptoms. And it tends to be localized. It's one side, it's one part of the breast. It's very tender to the touch. It's real warm to the touch. It can go all the way up to the lymph nodes, depending on how significant in location. So nursing, making sure she's nursing really well. You do encourage, while she's got mastitis, to breastfeed, to pull out the milk. I always stress putting the nose of the baby pointing while she's nursing at the redness, because that'll draw out the milk. You want to get that bacteria out of the breast. It doesn't take much to get mastitis. That milk, a little bit, once the baby's done nursing, it pulls back into the breast, and the baby has bacteria. If there's cracks on the breast, I mean, it doesn't take much for our normal healthy skin bacteria to get inside that warm, dark area of the breast and have a weaker immune system. So this is more of an abscess where it gets more severe. So you want to be careful. You want to get antibiotics going, whether it's just mild in the beginning or not, because it can quickly go into an abscess, which is a wound. It's a surgery. It's pretty significant. We want to get a good milk supply and get her healthy as soon as possible. So here's a picture of just some mild mastitis. You can see the redness under the nipple, and just getting the baby and putting warm compresses, trying to keep her breast to air as much as she can, just to help if there's cracks to healing. It's very tender. It's very warm. They're going to describe flu-like symptoms. So there's 2 different kinds. There's the mammary cellulitis, an inflammation of the connective tissue between the lobes of the breast, and then there's the mammary endonitis, the infection of the ducts and lobes of the breast. To be honest, I don't really care and know. I just know she has mastitis. You'd have to do more further testing. The treatment's the same, the assessment's the same. It's just where the specific infection is located. So development of mastitis, these are a few different ways. First-time moms have a higher chance of getting a poor latch. They're new to the whole transition of having a baby. There's just a lot. So I really stress taking care of the moms, getting them good sleep, getting a good support system schedule, getting her food, getting a good lactation support so that she nurses well and she gets herself taken care of. There's other reasons that can cause mastitis. I hinted at it. My kid was 1.5 years old, and it was that weaning time. If you quickly wean your baby and that milk stays in there and it's a warm, dark area and it's not being expressed, you want to gradually wean your baby off. Maybe long travels. Mine was jet lag and flying and not being able to nurse our usual routine. I was exhausted. My time change was all off. You start supplementing, that extra milk stays in there. The definition of a lazy feeder more has to do with they're kind of suck, they hang on the breast and then they fall off and then they suck. They tend to cause more trauma. They're not transferring the milk real well. They're not keeping that supply up. So it's just a cyclical cycle. You can get nipple trauma, weakness, you can get engorgement, you're not getting a good letdown, and then it just eventually goes, the bacteria gets in there, she's tired, she gets mastitis, and it definitely needs to be treated. And if it's not treated, most of them go to breast abscesses. So I do not mess around. If you're a birth assistant, you'd go to a postpartum visit, or you're a midwife that can't prescribe antibiotics, definitely talk with your collaborating physician and get her some general antibiotics to what she's not allergic, and get it taken care of right away. So treatment, we talked about it. The rest, warm, hot compresses, that's so important. Do not stop breastfeeding. The milk contains the bacteria, but it also contains the antibiotics. It contains, because the mom and baby can pass it back to each other. The sudden stopping of breastfeeding will cause very severe engorgement and just further complicate. She has a higher chance of abscess. The bacteria is just sitting there. You have a much more aggressive infection occurring. If it's too painful to breastfeed, she could pump, but I do encourage the baby to the breast because it'll get more of the milk out and it'll actually pull the infection better. So yeah, so the important things, it's hard to prevent. Just wash your hands really well. Nursing off and getting a good position, taking care of yourself. The weaker immune system, poor latches, poor hygiene, you're setting yourself up for mastitis. So complications, it's a big deal because it can go into a breast abscess. The couple times I've seen it, it's just nasty, this deep wound inside the woman's breast because it didn't heal and that infection just grows and grows and grows. Thromboembolic disease is very rare, thank goodness. I personally never seen it with one of my ladies, and I hope I never do. Leiden factor 5s and different predisposing conditions that I would hope we'd be assessing when prenatally and making sure they're a good candidate for birth. If all their moms and aunts had blood clots during labor, you'd probably want to be considering delivering her in the hospital. So these are those rare situations. You just didn't have much warning in her medical history. So predisposing factors, she's not getting out of bed much. She's sitting all the time. That blood's not circulating really well in her feet. After a C-section, she has a lot of pain. Family's doing too good of a job taking care of her. She's got to get up and move. It's a very serious medical emergency if the symptoms are occurring. If your lady calls postpartum and she's all of a sudden having sudden onset of the pain, tenderness in her calf, there's redness, she's got temperature, positive home inside is pulling back the ankle and getting a lot of pain in that calf area. If she has any of the first three, I don't even mess around. I tell her to go to the ER right away because the worry is that clot moves and it goes in her lungs and it could kill her. So a thrombolytic disease is a medical emergency. Many times the hospital system can give just blood thinners. I've seen it where they've had to do a procedure where they put in a screen just so it doesn't circulate. I mean, it's not going to kill her in her leg. It's the worry of where it's going to move to. So it's a big deal. So treatment, we talked about it already. You want to break the clot up. You want to not encourage the clot to move. I'm not going to tell her to massage the site. I'm not going to tell her just to stay at home and see how things happen. This is really serious, and she needs to go to the hospital because of that rare, once it moves, it can go into her lung, and a pulmonary embolism is a high mortality rate. So postpartum psychiatric disorder, mental health problems can complicate the postpartum period. In today's age, there's more and more being expected out of women with shorter amount of times. The dad's working, she's expected to go back to work. They don't have family close by. Mental health is so important. And unfortunately, our healthcare system takes it a very low budgetary and preventative stance, just a little bit under maternity health care. So I really stress as midwives and birth assistants, we want to give them high quality care prenatally, lots of education, support, a great birth experience, and postpartum when we have the advantage, we're seeing them day 1, day 5, 2 weeks, and 6 weeks. We get a good relationship. Being preventative, I would say I have less ladies that had depression, anxiety, in that extreme rare psychosis, but it can happen. It's a lot for a woman, all the changes in her body, all the expectations with nursing and the bleeding, the tenderness, the soreness, her nights and days backwards, so many questions with her and her baby. Is this normal, not normal? You want to do lots of education, lots of support, and sometimes it's an underlying medical condition. If she has low vitamin D and some extra bleeding, she's going to have more depression symptoms. She's going to have more issues with milk supply, and it's a cyclical effect. So you just really want to follow up. A traumatic birth, oh my goodness, it may not hit her the first few weeks. It may be 6 months to a year later. So following up with women, doing an Edinburgh score and getting a wellness mental health exam is so important. So these are different mood disorders that can occur: anxiety, depression, postpartum blues, bipolar disorder. The less common and very rare is the psychosis. So we'd expect a mom and a parent to be anxious and to feel a little overwhelmed. Everything's so new. It's okay with all the hormonal shifts to be smiling and happy, and then all of a sudden the tears are coming down. That's normal. But there's a balancing act of going from she doesn't even want to get out of bed, she's crying all the time, she's having very concerning thoughts about her baby, she really is in a dark place, and that can affect the bonding, and it can affect so many things in her recovery process and the family. And so you really want to do a good assessment. You want to try to get to the root of the problem. Baby blues affects 50 to 80% of women. It's usually self-limiting. It's more of the support. It can be up to 10 days. We want to just tell her, like I just gave the example, she's tearful yet happy, she's feeling overwhelmed, there's just so many changes, especially first-time moms. I see it more often. Just good self-care, support system, meal preps, having somebody watch the baby so mom can get a good hard nap. She's not responsible for the other kids or the chores or cooking or cleaning. Breastfeeding support groups are really helpful. You can connect with other moms in the community and build a community resource for each other, which is so important to me. So postpartum major mood disorder, that postpartum depression, it's a little more significant first-time moms, if she's had a history of depression, if she doesn't have as much social support. So she lives in Alaska and all her family is in Florida, and her husband's in the Air Force and he's overseas right now, and she doesn't know anybody. She's going to have a lot higher chance of depression than somebody that has her mom and all her sisters around her, and she has a strong partner that's in the mix to help with the needs and transition. And there's different levels. You can do support groups, you can get a counselor involved. I rarely do medications just because it's not getting to the root of the cause, and it has risk with nursing and side effects. Just a simple thing of childcare assistance, helping with the other kids, the cleaning, the meal preps. It's those little things, eating well, drinking lots of water, sleep. It affects a lot of those mental health symptoms. Psychosis is extremely rare, but it's very, very serious. Those are those ladies that you see those sad stories that they killed their baby, they're inpatient, they're just delirious. They've went so extreme off the deep end that they are in an altered state of reality. They're not even like mentally with them. They're the bonding, the hysteria that is present. It's extreme, but it truly happens. If you see a lady that's going down that path, you need to get her help immediately. So treatment for mood disorders, we talked about the drug therapy briefly, the counseling, psychiatrics. I'd say the biggest is bonding and self-care. I mean, if she's having trouble nursing, she had a traumatic birth, we need to get to the root of her being able to express her feelings and nursing well, and whatever is hurting, if she's not getting enough water, she's not getting enough sleep, we need to get to the root of the problem that's really not allowing her to take care of herself. So summary of the postpartum hemorrhage and the complications that can happen postpartum, including infections. The main things you want to think about, postpartum hemorrhage is a very serious condition in a third world country. That's the #1 reason women will die from childbirth. And most of the time it's a uterine atony. It's that uterus not firming up well. Sometimes it can be from a laceration that didn't get repaired correctly, just is oozing and doesn't clot off on its own. Retained parts, whether it's clots, amniotic sac, or placenta, is less rare, but it can be very serious. Hematoma is the least common to happen, and that's that deep rectal pain that they're not actively bleeding but showing signs of postpartum hemorrhage. Uterus inversions, turning the placenta, pulling on it and turning the uterus inside out, medical emergency. I've personally never seen it in the out-of-hospital setting. Placenta accreta, the couple times I've seen it, had to do with multiple C-sections and that extensive scar tissue on the uterine wall, causing the placenta to grow past where it's supposed to. Endometritis, I have personal experience with that, and it is rare. We're very fortunate in out-of-hospital births that we have minimal vaginal exams. We have a lower risk of infection. Their water usually breaks naturally on its own right before the baby comes. It's pretty rare, but you know, sometimes the placenta gets a little bit of clots, or the membranes get retained, or you just had a few multiple exams, or the group beta strep was present and she's tired and a weaker immune system. Sometimes we just don't know. You can have local vaginal infections, a lot of times at a repair site, and just getting some antibiotics and getting that wound taken care of. Mastitis, the infection in the breast, very serious. Don't want it to go into an abscess. Thrombolytic disorders, that's that blood clot, very serious medical condition. It usually starts in the calf, and you want to get her to the hospital and get that taken care of before it does move into the lung. Mood disorders and postpartum psychosis are so important. They're prevalent in the extreme in today's society, and it's just giving women the opportunity to recover and bond and be with their babies. Make sure we're preventing that bleeding. They're nice and healthy. They're getting their vitamin D, they're getting their vitamins and minerals, still taking their multivitamins, the bonding's going well with baby. We just really have to take care of our mamas.